Welcome to the Creative Commons RX podcast. Before diving into this episode, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.
If you've been following the cutting edge of medicine, you know the frontier has moved far beyond simple chemistry. We are no longer just dealing with synthetically manufactured pills. We're talking about therapeutics based on complex, engineered proteins, drugs, made in living systems that fundamentally interface with and often, reprogram the human body. Welcome back to the deep dive. Our mission today is to give you a foundational overview of these advanced therapeutics, specifically the biological drugs or biologics. The goal is simple, a deep understanding of what separates them from traditional small molecules. We want to look at the key classes, monoclonal antibodies, fusion proteins, cytokines, and cell therapies, and explore why their unique risks demand a completely different approach to safety.
And that differentiation is absolutely everything. For you, the listener, the core conflict, if you like, in therapeutics really boils down to this fundamental origin story. A traditional small molecule is a low molecular weight compound manufactured synthetically in a lab. Simple, predictable chemistry.
Right.
In contrast, a biologic is a large, complex molecule, often a protein, created using recombinant DNA technology within living systems. A cell line, maybe a microorganism. And this structural origin, this basic fact, determines everything about its mechanism of action, how the body handles it, and critically, the unique, often immune-driven safety risks it presents.
Okay, let's kick things off with the physical differences, because the scale difference you mentioned, it's just astounding, isn't it? When we talk about a small molecule, we're usually looking at something structurally pretty simple, molecular weight under, say, 1,000 Daltons.
Yeah, that's about right. Less than 1,000 Daltons is typical. It's tiny, really designed to slip almost anywhere.
But when we talk about a biologic, what kind of scale are we actually referencing?
Well, we're talking about a difference in magnitude that's almost hard to wrap your head around. Biologics, like monoclonal antibodies, they're massive. They're complex proteins that can weigh hundreds of thousands of Daltons, sometimes over 150,000 Daltons.
Wow.
Think of it like this. A small molecule might be a single Lego brick. A monoclonal antibody, by comparison, is like an intricately constructed multi-story building, fully articulated.
That's a great analogy.
And this scale difference isn't just academic trivia. It dictates everything about its manufacture. Because they're made in living systems, they carry an inherent variation.
Okay, you make that complexity sound like a feature, but doesn't that inherent lot-to-lot variability, because it's made biologically, introduce massive regulatory uncertainty and risk compared to something simple like, say, aspirin?
That's really a central question, and it's precisely why the regulation for biologics is so incredibly stringent. You're absolutely right. Lot-to-lot consistency is probably the single biggest challenge. A traditional synthetic molecule is chemically identical every single time. But with a biologic, processes like post-translational modifications, and the most famous one is glycosylation, the addition of sugar chains to the protein.
Oh, right, the glycosylation pattern.
Exactly. Those things occur naturally within the host cells. And this means that minor differences in the structure, maybe in the end glycosylation chain, can happen from batch to batch.
So, using your building analogy, the basic structure of the antibody building is identical, but maybe the paint job or the trim details might vary subtly because it was built by a living assembly line, not just stamped out by a machine.
That's a perfect way to put it. And this is why biosimilar manufacturers have such a high bar. They have to rigorously demonstrate that the patterns of these structural variations are highly similar to the original reference product. It's a concept completely foreign to small molecule generics.
Okay, so that sheer size and complexity immediately dictates how the body processes the drug. Let's talk PK, pharmacokinetics, how the drug moves through the body. Most people listening are used to taking an oral pill maybe once or twice a day. Why can't biologics usually be taken that way?
Well, there are two main reasons, directly related to their size. First, you just can't give these large, unstable proteins orally. The GI tract, the acidic environment, the digestive enzymes,
Yeah.
it would just chew them up immediately.
Right, they wouldn't survive.
Not a chance.
Yeah.
So they have to be administered parenterally, usually via injection, either intramuscular IM or intravenous.
Or IV.
Okay. And the second reason,
Second, their large size really restricts their distribution in the body. They're generally confined to the vascular system, the bloodstream, or maybe the extracellular fluid around cells. They simply can't easily slip through capillary walls and get deep into tissues the way small molecules can.
and that restricted movement,
Yeah,
that leads to an incredibly long half-life, doesn't it?
it does, yeah. Small molecules, they're typically metabolized by the liver using that CYP or cytochrome P450 enzyme system.
Like CYP3A4, yeah, exactly. And that gives them a relatively short half-life, usually in the range of 12 to 24 hours, which demands frequent dosing, like once or twice a day. Biologics, on the other hand, because they're largely stuck in the plasma, they're cleared differently. They're cleared via endogenous protein catabolism. Basically, the body breaks them down just like it breaks down its own natural proteins.
So they're essentially recycled by the body's normal protein turnover.
In a way, yes. And a major benefit of this is that because they don't rely heavily on that CYP system in the liver, they're much less likely to cause those dangerous drug interactions you see with many small molecules metabolized that way.
That's a key advantage.
Absolutely. And furthermore, they boast an incredibly long plasma half-life, often measured in weeks, not hours. Take bevacizumab, a common monoclonal antibody used in cancer. Its half-life is around 4 weeks.
4 weeks.
Yep. And this long half-life allows for highly convenient intermittent administration, infusions every few weeks instead of daily pills.
Okay, so that structural difference also feeds directly into the key mechanistic split, how they work. Extracellular versus intracellular targeting. Where do small molecules typically do their work?
Small molecules are built for the inside of the cell. They need to penetrate the cell membrane, which is relatively easy for them because they're small and often lipophilic, meaning they like fatty environments like cell membranes. Their primary function, especially in areas like oncology, is often to act as kinase inhibitors. They sneak inside the cell and they block the adenosine triphosphate, or ATP, binding domain of an enzymatic protein, a kinase.
This is our break the machinery inside the factory analogy from before.
Precisely. They're trying to stop the enzyme from getting the energy molecule, ATP, that it needs to send signals. The major consequence, though, is often a lack of pinpoint specificity.
How so?
Well, that ATP binding domain, the place they target, is often highly conserved, meaning it looks very similar across multiple different enzymes, multiple kinases. So most approved kinase inhibitors actually inhibit several enzymatic sites, not just the one intended target.
Which leads to off-target effects.
Exactly. You inhibit a broad spectrum of target kinases, and consequently you get many off-target effects, or toxicities, in healthy cells that also happen to use those kinases.
Okay. And the large biologics, then, confined mostly to the outside of the cell, have to operate completely differently.
They absolutely do. Monoclonal antibodies, for example, are usually highly specific. They're designed to target just a single extracellular receptor on the cell surface, or perhaps a circulating ligand, like a growth factor, floating around outside the cell. By binding to the receptor's external domain, think of cetuximab blocking the epidermal growth factor receptor, EGFR. They physically prevent the natural ligand, the normal signal, from attaching and activating all the downstream signaling inside the cell.
So they just lock the loading dock door from the outside, stopping the signal before it even gets started.
That's the perfect analogy. They stop the signal transmission from the outside in. High specificity, extracellular action.
So because biologics often work by manipulating these large protein complexes and, crucially, leveraging the body's own defense mechanisms, understanding the immune system itself becomes non-negotiable, right? It's the battlefield.
Absolutely essential.
Yeah.
If you want to understand biologics, you have to understand the immune system they interact with.
Okay, let's review the two main arms of defense that make up this battlefield. Where do we start?
We start with innate immunity. This is the host's first line of defense. It functions immediately upon exposure to something foreign or dangerous. And the crucial thing to remember here is that this arm is non-antigen specific. It doesn't recognize specific invaders.
It's like the generalized, always-on security system, the first responders.
Exactly. It uses germline-encoded receptors called pattern recognition receptors, PRRs, to recognize very general molecular structures found on many pathogens. These are called pathogen-associated molecular patterns, PAMPs. Basically, common danger signals.
And who are the key players in this innate response?
Key cells include macrophages, which are like the cleanup crew, engulfing debris and pathogens. Dendritic cells, or DCs, which are critical messengers that bridge innate and adaptive immunity. And natural killer, NK cells.
NK cells sound important.
They are. They patrol the body and are particularly good at killing virus-infected cells or tumor cells, especially those tricky ones that try to hide by getting rid of their major histocompatibility complex, or MHC markers.
Okay, so innate immunity is the fast general response. If that's overwhelmed or if a more specific response is needed, we call in the specialized forces adaptive immunity.
That's right. Adaptive immunity is highly specific, it's learned over time, and critically, it has memory. This is where the real complexity and the power for therapies resides.
And adaptive immunity has two main branches.
Correct. First, there's humoral immunity. This is primarily driven by B lymphocytes, or B cells. When activated, B cells mature into plasma cells that produce antibodies, also known as immunoglobulins.
And what do these antibodies do?
They have several jobs. They can neutralize a pathogen directly just by binding to it. They can act as opsonins.
Opsonin?
Yeah, think of them as molecular flags. They code a target, marking it for destruction by other immune cells like macrophages. Or antibodies can activate the complement cascade, another defense system in the blood.
Okay, that's humoral, antibody-based. And the second branch is cellular immunity.
Right, this is mediated by T lymphocytes, or T cells, which mature in the thymus gland.
And T cells come in different flavors, too.
They do. Broadly, we have the CD8 plus cytotoxic T cells. These are the direct killers. They recognize and destroy tumor cells, or cells infected with viruses. And then we have the CD4 plus helper T cells. These are arguably the crucial regulators, the generals, organizing the entire immune response. They do this primarily through the release of signaling molecules called cytokines.
And these helper T cells can push the response in different directions.
Yes, they can differentiate into subtypes. For example, Th1 cells tend to drive cell-mediated immunity, boosting those cytotoxic T cells. Th2 cells, on the other hand, tend to promote B-cell proliferation and antibody production, supporting the humoral response.
Okay, and T cell activation itself, which is so central to therapies like checkpoint inhibitors and SAR-T T cells, that's not a simple on-off switch, is it? It requires multiple signals.
Absolutely not simple. It's a carefully controlled process. T cells generally require two primary signals to become fully activated and ready for action.
What's signal one?
Signal one is the specificity signal. It's the T cell receptor, or TCR, on the T cell physically engaging with the MHC peptide complex presented by an antigen-presenting cell, like a dendritic cell. This tells the T cell what to recognize.
But that's not enough on its own.
Usually not. You almost always need signal 2, which is the co-stimulatory signal. A classic example is the CD28 receptor on the T cell binding to its partners, CD80 or CD86, on the antigen-presenting cell. This basically confirms the danger signal.
And what happens if a T cell gets signal 1 without signal 2?
Often, it leads to a state called anergy, which is basically functional unresponsiveness. The T cell recognizes its target but doesn't get the go signal, so it shuts down. This is a key safety mechanism to prevent accidental activation against self.
That makes sense. Okay, so all these immune cells need to talk to each other. That brings us to the communication network, the cytokine signaling network. It's famously complex, almost bewilderingly so.
It is incredibly complex, and that complexity arises mainly from two defining characteristics. The first is redundancy, meaning that many different cytokines can often elicit the same or very similar biological functions. So if one is missing, another might be able to step in.
Okay, and the second characteristic?
Pleiotropism. This means that one single cytokine molecule can act on multiple different types of cells, and sometimes it can have completely different, even opposite effects depending on the cell type and the context. This creates this vast, interconnected, sometimes confusing network of signals.
It sounds less like a simple command structure and more like a complex web of influences.
That's a very good way to put it.
And these signals, these cytokines, they don't just float around randomly hoping to bump into the right cell, right? They often rely on a highly organized, step-by-step process inside the cell to transmit the message from the outside all the way to the nucleus where the genes are.
Yes, absolutely. The classic and incredibly important pathway used by many cytokines and also growth factors is the JAK-STAT pathway. That stands for Janus kinase signal transducer and activator of transcription.
Okay, JAK-STAT. That sounds important. Let's pause there for a second because this seems like a core mechanism we need to understand. What are the key steps involved?
Okay, so it starts when the cytokine binds to a specific receptor on the outside of the cell membrane. This binding causes the different subunits of the receptor to come together or undergo apposition, kind of like puzzle pieces clicking into place.
Got it. Receptor subunits come together.
This alignment then activates the associated JAK enzymes, Janus kinases, which are inside the cell but physically tethered to the receptor tails. They essentially wake each other up.
So, the cytokine binding outside flips a switch on the JAKs inside. What do the activated JAKs do next?
The activated JAKs immediately start doing what kinases do best. They phosphorylate things. Specifically, they phosphorylate specific tyrosine amino acids on the cytoplasmic tail of the receptor itself. These newly phosphorylated tyrosine sites now serve as highly specific docking stations, like precisely organized landing pads for the next molecules in the chain.
And those landing pads attract the STAT proteins, hence the name JAK-STAT.
Exactly. The STAT proteins, which were just floating around in the cytoplasm, now recognize and bind to these specific phosphorylated docking sites on the receptor tail. Once docked, the STAT proteins themselves get phosphorylated by the active JAKs. This phosphorylation causes them to detach from the receptor, pair up with another phosphorylated STAT protein to form a dimer, and then, crucially, this STAT dimer translocates it moves into the cell nucleus.
So it carries the message directly to the command center.
Precisely. Once inside the nucleus, the STAT dimer binds to specific DNA sequences and modifies gene expression. It tells the cell which genes to turn on or off in response to that initial cytokine signal. So the STAT protein acts as the messenger carrying instructions from the cell surface right to the DNA.
That's a really elegant pathway. Before we move into how we use biologics therapeutically, let's briefly touch on another type of signaling protein, the ones that direct the physical movement of immune cells.
Yes, you're talking about the chemokines. They're essentially chemotactic cytokines.
Chemotactic meaning?
Meaning they attract cells. They're small secreted proteins, and they signal primarily through a different type of receptor called G protein-coupled receptors, or GPCRs. Their entire function is to orchestrate the migration, the directed movement or chemotaxis, and the precise localization of white blood cells, the leukocytes. They create chemical gradients that immune cells follow.
So they act like molecular GPS signals for immune cells, telling them where to go.
That's a fantastic analogy. They are absolutely central to immune surveillance, directing cells to sites of infection or inflammation, and basically choreographing the immune response in space and time.
Okay, we've established the fundamental differences between biologics and small molecules, and we've looked at the immune system battlefield. Now let's dive into the clinical applications. The most common therapeutic tool here is surely the monoclonal antibody, the mAb. We know they can block signals directly, but you mentioned earlier the brilliance often lies in their ability to indirectly weaponize the patient's own immune system. How does that work?
Absolutely. The direct mechanisms are relatively straightforward. The Fab portion of the antibody, the arms of the Y, acts as that highly specific blocker we talked about, preventing a ligand from binding its receptor, maybe preventing receptor dimerization or sometimes even directly triggering apoptosis or cell death in the target cell. But the real power often comes from the Fc region, the stalk of the Y-shaped antibody. This Fc region is the key to recruiting the host's own defense mechanisms.
Okay, so how does it recruit help?
We rely on two major indirect mechanisms mediated by the Fc region. The first one is called ADC. That stands for antibody-dependent cell-mediated cytotoxicity.
Okay, let's unpack that name. Antibody-dependent cell-mediated cytotoxicity.
Right. It means the killing effects, the cytotoxicity, is mediated by another immune cell, but it's dependent on the antibody being there first. Here's how it works. The Fc region of the mAb, once the antibody is bound to the target cell like a cancer cell, acts as a flag that recruits immune effector cells, typically natural killer, NK cells, or sometimes macrophages, which have specific receptors on their surface that recognize and bind to that Fc region.
So the antibody acts like a bridge.
Exactly. Once the NK cell binds to the Fc region of the antibody coating the target cell, the NK cell gets activated and is stimulated to destroy that target cell, usually by releasing cytotoxic granules containing proteins like perforin and granzymes. This is precisely how rituximab works to treat certain B-cell cancers or autoimmune diseases. It coats the target B cells and then recruits NK cells to come along and eliminate them.
That's amazing. We're essentially painting a target on the bad cells and letting the patient's own NK cells do the killing, guided by this precision antibody. Okay, that's ADCC. What's the second mechanism, CDC?
CDC stands for complement-dependent cytotoxicity. This mechanism involves a different part of the immune system called the complement cascade.
Complement. That's a system of proteins in the blood, right?
Yes, it's a complex system of plasma enzymes and effector proteins that normally helps clear pathogens. Here, the FSC region of certain types of antibodies like IgG1 or Ig3, when bound to the target cell, can bind the first component of the complement cascade, C1 key. This binding triggers a chain reaction, a cascading activation of subsequent complement proteins. This cascade culminates in the formation of something called the membrane attack complex, or MA.
Membrane attack complex. Sounds dramatic.
It is. The MAC essentially punches holes in the membrane of the target cell, leading directly to cell lysis. The cell breaks apart and dies. The CH2 domain within the FSC region of the IgG antibody is often critical for initiating this complement cascade.
So two powerful ways the antibody tail can recruit the body's defenses: bringing in killer cells, ADCC, or triggering this hole-punching complement system, CDC.
Exactly. And the ability to engineer these FGC regions to enhance one mechanism or the other is a major area of antibody development.
Now, MABs have evolved way beyond just being simple blockers or recruiters. Let's look at a couple of specialized applications, starting with using them as targeted delivery vehicles. Antibody drug conjugates, ATCs.
Oh, ADCs. These are incredibly clever constructs.
Mhm.
They basically use the monoclonal antibody as a highly specific guided missile, a homing device, to deliver an extremely potent cytotoxic payload, usually a chemotherapy drug that's too toxic to give systemically directly to the cells that express the target antigen while minimizing exposure to healthy tissues.
So the antibody finds the target cell, and then what?
The antibody binds to its specific target antigen on the surface of the cancer cell. The entire complex antibody drug and receptor is then internalized by the cell, usually through a process called receptor-mediated endocytosis. It gets pulled inside. Once inside the cell, typically within compartments called lysosomes, the linker connecting the antibody to the cytotoxic drug is cleaved, releasing the potent drug right where it needs to be to kill the cancer cell from within.
That sounds conceptually brilliant, but the engineering challenge must be immense. You need to keep that highly toxic payload securely attached while it's circulating, but then ensure it gets released perfectly once it's inside the target cell.
It is absolutely a delicate balancing act. The chemistry of the linker is critical. It has to be stable enough in the bloodstream to prevent premature release of the toxic drug, which would cause systemic side effects. But it also needs to be labile or breakable under the specific conditions found inside the target cell, like the acidic environment or specific enzymes within the lysosome. A prime example you might know is adotrastuzumab emtansine, brand name Kadcyla. This ADC uses the antibody trastuzumab, which targets the HER2 receptor found on some breast cancers, to deliver a potent microtubule inhibitor payload specifically to those HER2-positive cancer cells.
Incredible precision.
Yeah.
Okay, and then there's the undisputed game changer in modern oncology, arguably one of the biggest breakthroughs in decades. Immune checkpoint inhibitors, ICIs.
Yes, ICIs have truly revolutionized the treatment of many cancers. These are monoclonal antibodies, but instead of targeting the cancer cell directly, they target the inhibitory pathways, the brakes, that tumors often exploit to suppress the body's own T-cell activity against them.
Explain the brakes analogy.
Think of a T-cell as a car that needs to attack a tumor. Signal 1, TCR, NHC, and signal 2, co-stimulation like CD28, CD80, 86, are like the gas pedal, getting the T-cell activated and moving. But T-cells also have inhibitory receptors, or checkpoints, on their surface that act like brakes to prevent overactivation or autoimmunity. CTLA-4 and PD-1 are two key brake pedals.
And tumors exploit these brakes.
Exactly. Many tumors protect themselves by expressing the ligands, the molecules that step on these T-cell brakes. For instance, a tumor might express high levels of PD-L1, which binds to the PD-1 receptor on the T-cell, sending an inhibitory stop-attacking signal.
So the immune checkpoint inhibitor drug, like ipilimumab, which targets CTLA-4, or pembrolizumab, which targets PD-1, does what?
It essentially blocks that inhibitory interaction. It cuts the brake line. By binding to either the checkpoint receptor, like PD-1 on the T-cell, or its ligand, like PD-L1 on the tumor cell, the ICI antibody prevents the stop signal from being delivered. This neutralization of the tumor's main evasion mechanism prevents T-cell suppression. It effectively releases the brakes on the anti-tumor T-cells, allowing them to become fully activated, sustain their attack, proliferate, and ultimately kill the cancer cells much more effectively. It unleashes the patient's own immune system against the cancer.
Truly remarkable. Okay, moving beyond antibodies that largely resemble naturally occurring ones, we have fusion proteins. These sound like bespoke, engineered biologics combining different functional protein segments.
That's exactly what they are. Their design philosophy is modular. You take functional domains from different proteins and fuse them together, often genetically, to create a novel therapeutic agent with desired properties. And a key engineering trick, as we discuss with antibodies, is often fusing the active domain, whatever it might be, to the FCC portion of an IgG1 antibody. Why? Because that FC region confers stability and, crucially, provides that long plasma half-life by engaging with the neonatal FC receptor, FcRn recycling pathway.
Clever. So they borrow the long-lasting tail from an antibody. How do these fusion proteins typically work? What are their mechanisms?
Broadly, they function in a couple of main ways. One major mechanism is to act as soluble decoy receptors. They essentially serve as molecular traps for circulating ligands or cytokines.
Give us an example.
Etanercept is the definitive classic example here, used widely for inflammatory diseases like rheumatoid arthritis. It consists of the extracellular ligand-binding domain of the human TNF-alpha receptor fused to the FPC region of human IgG1. So this engineered protein floats around in the circulation and acts like a massive sponge, binding up and neutralizing the pro-inflammatory cytokine TNF-alpha before it combined to its real receptors on cells and cause inflammation.
So it mops up the bad signal?
Precisely. Another critical example, particularly in cancer and eye diseases, is Ziv aflibercept, also known as the VEGF trap. This fusion protein cleverly combines domains from two different VEGF receptors, VEGFR1 and VEGFR2, and fuses them to an FC region. This allows it to bind and effectively sequester all major forms of VEGF ligands, strongly inhibiting the pro-angiogenic signaling needed for tumor growth or abnormal blood vessel growth in the eye.
Very effective trapping. Okay, what's the second main mechanism for fusion proteins?
The second major mechanism involves targeted immunosuppression, specifically through immune co-stimulation blockade.
Blocking that critical signal, too, we talked about for T-cell activation.
Exactly. This is a beautiful example of using an engineered biologic to achieve a very subtle but profound immunomodulatory effect. Consider abatacept, another drug used for autoimmune diseases like rheumatoid arthritis. Abatacept is an engineered fusion protein consisting of the extracellular domain of CTLA-4. Remember, CTLA-4 is normally an inhibitory receptor on T cells that binds to CD8086 fused to an FC domain.
Okay, so it uses the binding part of an inhibitory receptor.
Yes. But instead of being on the T cell, the soluble CTLA-4I fusion protein circulates and binds with high affinity to the CD80 and CD86 ligands on the antigen-presenting cell. By doing so, it physically blocks these ligands from engaging with the CD28 receptor on the T cell. It essentially outcompetes CD28 for binding to CD8086, thereby preventing the delivery of that crucial CD28 coactivation signal, signal 2. Without that critical second signal, T cells cannot achieve full activation, even if they receive signal 1. This leads to reduced T-cell proliferation and effector function, which is why abatacept is highly effective in dampening down the autoimmune response.
That's really elegant, using a piece of an inhibitory molecule to block an activating signal.
It is. It shows the power of rationally designed fusion proteins.
Okay, next up, let's briefly turn to cytokines themselves, the actual communication signals of the immune system. When they're used therapeutically, presumably they harness that powerful JAK-STAT network we detailed earlier to modulate immune responses.
Yes, that's the idea. Therapeutic cytokines, like various interferons and interleukins, are administered to try and boost or modulate specific immune responses. For instance, type I interferons, like interferon alpha, have been used for their potent antiviral activity in chronic infections like hepatitis B and C, and also for some cancers. Interleukin-2, or IL-2, also known by the drug name aldesleukin, was one of the early immunotherapy agents. It's used, albeit less commonly now due to toxicity, to promote the activation, proliferation, and cytotoxic killing activity of T cells and NK cells, particularly in cancers like metastatic melanoma and renal cell carcinoma.
But using these natural signals directly sounds inherently risky, especially given that property of pleiotropism you mentioned earlier, one cytokine affecting many cell types. How does that complexity translate into a clinical challenge when you try to dose these agents?
You've hit on the core issue. It creates a massive clinical dosing challenge, and frankly, it's the major limitation of using many cytokines directly as therapies. Because of pleiotropism, the receptors for these cytokines are often widely distributed throughout the body on many different cell types, not just the immune cells you want to target.
So you get widespread effects, wanted and unwanted.
Exactly. To achieve the necessary dose to generate the desired anti-tumor effect, say, Using high-dose IL-2 to really stimulate those cytotoxic T cells, you often end up triggering severe systemic toxicities because that same cytokine signal is also hitting, for example, endothelial cells lining blood vessels and other tissues. High-dose IL-2 is notorious for causing things like vascular leak syndrome, where fluid leaks out of blood vessels leading to low blood pressure and multi-organ failure. We really struggle to find a therapeutic window, a dose that gives efficacy without causing life-threatening side effects.
Which probably explains why we now often use biologics designed to block cytokine signaling in inflammatory diseases.
Precisely. Drugs like tocilizumab, which is a monoclonal antibody that blocks the receptor for IL-6, are used to counteract excessive or pathogenic cytokine signaling in conditions ranging from rheumatoid arthritis to the dangerous cytokine release syndrome we'll discuss later. Blocking cytokines is often safer and more targeted than trying to administer them systemically.
Okay, that makes sense. Finally, in this section, we reach what are often called living drugs, vaccines, and cellular immunotherapy. Starting with vaccines, the fundamental goal is still the same as it's always been, right? To create immunological memory.
Absolutely. Vaccines are designed to induce protective immunological memory by initiating a controlled adaptive immune response, both humoral antibodies and cellular T cells, against specific antigens from a pathogen, without causing the actual disease.
And the platforms we use to deliver these antigens have become increasingly sophisticated.
Very much so. We've moved beyond just using weakened or killed whole pathogens. We now have highly purified recombinant protein vaccines, where just a key antigen, like the hepatitis B surface antigen, is produced safely in large quantities using recombinant DNA technology, often in yeast or insect cells. These are very safe and effective.
We also hear a lot about viral vector vaccines.
Yes, viral vector vaccines use harmless or weakened virus, like an adenovirus, as a sort of shuttle vector. You insert the gene encoding the antigen from the target pathogen, like SARS-CoV-2 spike protein, into the adenovirus genome. When the vector vaccine infects host cells, it delivers this gene, and the host cells then produce the antigen, triggering the immune response. Adenovirus vectors are useful because they can carry large genetic payloads and tend to induce strong immune responses.
And then, of course, the technology that really came to the forefront recently, mRNA vaccines.
The mRNA vaccine platform was a true breakthrough, enabled by decades of research. The key innovation was the effective encapsulation of the fragile messenger RNA, mRNA, which carries the genetic code for the target antigen within protective lipid nanoparticles, LNPs.
Why are the LNPs so important?
They do two crucial things. First, they protect the delicate mRNA molecule from being degraded by enzymes in the body before it can reach the target cells. Second, they help the mRNA get inside the cells. Once inside, the cell's own machinery reads the mRNA blueprint and temporarily manufactures the antigen protein, like the spike protein. This locally produced antigen then strongly stimulates the adaptive immune response.
And a key safety advantage of mRNA.
A really key safety advantage is that the mRNA molecule itself is temporary. It's naturally degraded by the cell within a day or two. And critically, because mRNA works in the cytoplasm and doesn't involve DNA or enter the cell nucleus, it carries virtually no risk of insertional mutagenesis, meaning it can't accidentally integrate into the host cell's genome and potentially cause long-term problems like cancer.
Okay, very clear. Now, for the ultimate impersonalized living drugs, CAR T-cell therapy. This is where we're truly using engineered cells as the therapeutic agent.
Absolutely. CAR T-cell therapy represents autologous cellular immunotherapy. Autologous meaning the therapy is derived from the patient's own cells.
Describe the process. It sounds incredibly complex. It's often called vein-to-vein.
It is complex, and vein-to-vein captures it well. First, the patient undergoes a procedure called apheresis, similar to donating blood components, to harvest a large number of their own T lymphocytes. These harvested T cells are then taken ex vivo, meaning outside the body, to a specialized manufacturing facility. There, they are genetically engineered, typically using a disabled viral vector, often a lentivirus, to insert a new gene into the T cell's DNA. This transgene encodes the instructions for making the chimeric antigen receptor, or CIR.
Okay, let's stop there for a moment. What exactly is a chimeric antigen receptor, CIR, and why is it functionally different from a natural T-cell receptor, TCR?
Great question. The CRR is a completely synthetic, engineered receptor protein that gets expressed on the surface of the T cell. It's chimeric because it combines different parts. Typically, it has an extracellular domain, often derived from the variable region of an antibody, that's designed to recognize a specific target antigen on the surface of cancer cells like CD19, which is found on most B-cell malignancies. Now, here's the critical difference. This external antigen binding domain is fused directly to intracellular T-cell signaling domains, like CD3 zeta, and co-stimulatory domains like CD28 or 41BB.
So it combines the targeting of an antibody with the activation machinery of a T cell.
Precisely. And what makes this revolutionary is that once these CRT cells are expanded in number, grown in the lab, and then reinfused back into the patient's vein, they can recognize and kill the malignant cells expressing the target antigen, like CD19+, without the limitation of the major histocompatibility complex, MHC.
Ah, that's the key difference from normal T cells.
That's the absolute key. Remember, normal T cells, via their TCR, need the target antigen to be processed and presented by MHC molecules on the surface of the target cell. Signal 1. CRT cells bypass this completely. Their CR construct recognizes the intact antigen directly on the cell surface, and because the signaling domains are built right in, binding immediately triggers potent T cell activation and killing. This MHC-independent activation is what makes them so powerful against certain cancers, but it also contributes to their unique and potentially severe toxicities like cytokine release syndrome.
We also see a different type of targeted cellular therapy used, sometimes called a therapeutic vaccine, like Sipuleucel-T for prostate cancer. How does that work?
Right, Sipuleucel-T is a bit different. It's also an autologous cellular therapy, but instead of engineering T cells, it focuses on activating the patient's own dendritic cells, DCs, which, as we discussed, are the most potent antigen-presenting cells, ABCs, in the body. In this case, the patient's peripheral blood mononuclear cells, which include DCs and their precursors, are collected via leukapheresis. These cells are then cultured ex vivo with a special fusion protein. This protein consists of prostatic acid phosphatase, APP, an antigen commonly found on prostate cancer cells, fused to granulocyte macrophage colony stimulating factor, GM-CSF, which is an immune stimulant that helps activate DCs.
So you're loading up the patient's APCs with the target antigen.
It's exactly. The DCs take up and process this PP-GM-CSF fusion protein, becoming activated and primed to present the PP antigen. These activated antigen-loaded DCs are then reinfused back into the patient. Once back in the body, they migrate to lymph nodes and effectively stimulate a specific, hopefully long-lasting T-cell response, both CD4+ and CD8+, against the patient's prostate cancer cells that express PPP. It's more about initiating a targeted adaptive immune response rather than direct killing by engineered cells.
The sheer complexity of these biologics, especially the cellular therapies, must force constant evolution in how they're regulated. Let's look at a case study, maybe, of how this regulatory transition can happen, focusing on a very familiar biologic. Insulin.
Insulin is a perfect case study of this regulatory evolution, almost a gray area historically. It is fundamentally a therapeutic protein, a hormone. It's large, complex, and produced in living systems, originally animal pancreas, now mostly recombinant bacteria or yeast. It clearly fits the definition of a biologic. Yet, for historical reasons, insulin products were regulated for decades under the Federal Food, Drug, and Cosmetic Act, FD&C Act, the pathway typically used for conventional chemical or small molecule drugs.
Why did that happen, and why did the transition eventually occur? Why did it matter?
It likely happened due to its early discovery and use before the modern biologics framework was fully established. However, a significant regulatory shift occurred more recently. As part of the Biologics Price Competition and Innovation Act, BPCIA, of 2009, Congress mandated that certain protein products previously approved under the FD&C Act, including insulin, would transition to be regulated as biologics under the Public Health Service Act, PHS Act, specifically Section 351. This transition formally happened in March 2020.
And why was this transition so pivotal? What did it enable?
It was pivotal because bringing insulin under the biologics pathway, Section 351 of the PHS Act, allowed for the development and approval of biosimilar and interchangeable biosimilar insulin products under the abbreviated pathway defined by Section 351K of the Act. This pathway didn't exist under the old small molecule regulations for insulin. So this transition directly enabled the first interchangeable biosimilar insulins to be approved, starting in 2021. These products are tracked in the FDA's Purple Book database of licensed biological products.
And interchangeable is key here, right? That means pharmacists can substitute them.
Exactly. An interchangeable biosimilar means it can be substituted for the reference product at the pharmacy without needing direct prescriber intervention, though state pharmacy laws vary. This works much like substituting a generic small molecule drug for a brand name one, and the goal is the same, to lower costs and increase patient access to these essential medicines.
That's a really clear example of regulation adapting to the nature of the drug. But what's fascinating, looping back to our earlier discussion, is how this classic therapeutic protein, insulin, finds itself battling against modern biologic targets, specifically the cytokine network.
That's a fantastic link that really ties these sections together. While insulin is the therapeutic biologic we administer, its efficacy in the body, especially in conditions like type 2 diabetes associated with obesity and inflammation, is significantly challenged by the patient's own endogenous cytokine network.
Oh, so.
We now understand that insulin resistance, the hallmark of type 2 diabetes, is substantially influenced, even driven by chronic low-grade inflammation. Adipose tissue or body fat, especially visceral fat, isn't just inert storage. It's an active endocrine organ that secretes pro-inflammatory cytokines. For example, TNF-alpha, which we discussed earlier as a target for etanercept, is a major mediator produced by adipose tissue that directly interferes with insulin receptor signaling in muscle and fat cells, making them less responsive to insulin. Interleukin-1 beta, IL-1 beta, is another cytokine implicated in impairing pancreatic beta cell function, insulin production, and reducing glucose uptake stimulated by insulin. So, in essence, the effectiveness of the insulin therapy is being hampered by pathogenic endogenous biologics, these inflammatory cytokines. Precisely, it highlights the deep interplay between metabolic health and the immune system, and how biologic pathways are central to both health and disease, even for a therapy as established as insulin.
Okay, let's pivot now to the core differences in the toxicity profiles. We touched on small molecules causing predictable, target-specific side effects based on where that target enzyme is also found in healthy tissues. Biologics, though, seem to cause distinct immune-mediated adverse events.
That's the fundamental difference in risk profile. The characteristic risks associated with biologics are fundamentally immunological in origin. For immune checkpoint inhibitors, ICIs, the major concern is IRAEs, which stands for immune-related adverse events.
Related to that, releasing the brakes mechanism.
Exactly. These are inflammatory side effects that occur because the newly unleashed T cells, while attacking the tumor, can also mistakenly attack normal, healthy cell tissues. This can manifest as potentially severe, sometimes fatal, inflammation in almost any organ system. Common examples include enterocolitis, inflammation of the gut, hepatitis, liver, pneumonitis, lungs, or endocrinopathies affecting hormone-producing glands like the thyroid or pituitary.
And how are these IRAEs managed?
Recognizing them early is critical. Management typically involves stopping the ICI drug and promptly initiating immunosuppression, usually with high-dose corticosteroids like prednisone, to dampen down that excessive immune response. For severe or refractory cases, other immunosuppressants might be needed.
Okay, and then the cellular therapies, IR T cells, and also some antibody constructs like bispecific T cell engagers, BiTEs. They have that unique, very acute, potentially life-threatening systemic reaction you mentioned earlier.
Yes, that is CRS, or cytokine release syndrome. This is a profound, systemic inflammatory reaction that typically occurs within hours or days after the infusion of the engineered cells or antibody. It's caused by the rapid, massive expansion and activation of the T cells, either the CIR T cells themselves or bystander T cells activated by BiTEs, and the subsequent torrential release of inflammatory cytokines into the bloodstream, most notably interleukin-6, IL-6, but also others like TNF-alpha and interferon gamma.
And this flood of cytokines causes the systemic problems.
It does. This cytokine storm leads to widespread activation of endothelial cells and other immune cells, causing symptoms ranging from fever and fatigue to severe, life-threatening complications like low blood pressure, difficulty breathing due to capillary leak in the lungs, organ dysfunction, and neurological toxicity, sometimes called ICANS immune effector cell-associated neurotoxicity syndrome. Because this activation is so powerful and rapid, the systemic response can be fatal if not managed appropriately.
And the specific management for CRS?
Management centers on intensive supportive care, fluids, oxygen, blood pressure support, and, crucially, targeted anti-cytokine therapy. The monoclonal antibody tocilizumab, which blocks the IL-6 receptor, has become the standard of care treatment for moderate to severe CRS. By interrupting that key IL-6 signaling cascade, it can often rapidly reverse the symptoms.
Okay, so CRS and IRAEs are distinct immune-mediated toxicities of biologics. Contrast that again briefly with the small molecule toxicities.
Right. The toxicities of small molecule drugs, like the tyrosine kinase inhibitors, are generally the predictable on-target consequence of shutting down that specific enzyme or pathway in healthy cells that also happen to rely on it. For example, small molecule inhibitors targeting the VEGF signaling pathway used to block tumor blood vessel growth inevitably also hit VEGF receptors on healthy blood vessels. This leads to predictable dose-related toxicities like hypertension, proteinuria, protein leaking into urine due to kidney effects, and impaired wound healing. Similarly, small molecule EGFR inhibitors designed to treat cancers driven by EGFR mutations frequently cause an acneiform rash, looks like acne, and diarrhea, because EGFR signaling is also very important for the normal function and maintenance of the skin and the lining of the gut mucosa. The toxicity is inherent to inhibiting the target pathway, wherever it's expressed. It's not typically an attack by the immune system itself.
That distinction is crystal clear. Now we come to a specific and very important safety signal that has emerged with a major new class of biologics and seems to hold massive implications for future advanced therapies, AREA, or amyloid-related imaging abnormalities. This is the major concern with the new anti-amyloid monoclonal antibodies being developed and approved for Alzheimer's disease.
Yes, the introduction of these anti-amyloid MABs, drugs like aducanumab, lecanemab, and donanemab, represents a potentially huge shift in how we approach Alzheimer's disease, targeting the underlying pathology. But they come with a very distinct and serious class effect related to cerebrovascular safety, ARA. It's crucial to understand that ARA is fundamentally an injury to the brain's blood vessels, likely related to the antibody interacting with amyloid deposits within those vessel walls, and it manifests in two primary forms that are visible on brain magnetic resonance imaging, or MRI scans.
Okay, what are those two specific manifestations seen on MRI?
The first is ARIA-E. The E stands for edema. This refers to vasogenic edema, which basically means fluid leaking out of compromised small blood vessels into the surrounding brain tissue. It often looks like swelling on the MRI scan. The second is ARIA-H. The H stands for hemorrhage. This includes cerebral microhemorrhages, which look like tiny little dots of blood signal on specific MRI sequences, and sometimes, more concerningly, larger superficial siderosis or macrohemorrhages, which are frank bleeds within the brain or on its surface.
And you said, while often asymptomatic, they can be serious. And they're common.
Both true. While many cases of ARIA, especially ARIA-E and microhemorrhages, are detected only on routine monitoring MRIs in patients who feel fine, they can cause symptoms like headache, confusion, dizziness, visual changes, nausea, and sometimes even seizures. Severe cases, particularly large hemorrhages, can be debilitating or even fatal.
And the incidence rates we're seeing in the clinical trials are far from rare, are they?
No, they're quite significant, clearly indicating this is a common risk with this class of drugs. For example, in the pivotal trials for aducanumab, ARIA-E was observed in up to 35% of participants receiving the high dose. For lecanemab, the rate was around 12.6%. ARIA-H rates are also substantial, often occurring alongside ARIA-E.
What's the presumed mechanism? Why do these antibodies cause leaky brain blood vessels?
The leading hypothesis is that these antibodies designed to bind and clear amyloid beta, A-beta plaques in the brain parenchyma, also interact with A-beta deposits located within the walls of cerebral arteries and arterioles, a condition known as cerebral amyloid angiopathy, CAA, which is very common in Alzheimer's patients. This interaction might trigger local inflammation, damage the integrity of the blood vessel wall, and lead to increased vascular permeability, resulting in the leakage of fluid, ARIA-E, or blood ARIA-H.
Okay. Given that this risk is common and potentially serious, personalized risk stratification must be absolutely critical before starting these therapies. What determines who is most susceptible to developing severe ARA?
You're absolutely right. Risk stratification is essential. And the single strongest genetic risk factor that has been consistently identified through pharmacogenomics, PGX studies, is the patient's APOE genotype, specifically the presence of the epsilon 4.
APOE epsilon 4. That's the same gene variant that's a major risk factor for developing Alzheimer's in the first place, isn't it?
Yes, it is. And individuals who carry one copy of the APOE4 allele have an increased risk of ARIA compared to non-carriers. And those who carry two copies, APOE4 homozygotes, have a substantially higher risk, particularly for symptomatic ARIA-E and recurrent ARIA-H. This genetic risk stratification, testing patients for their APOE genotype, is now considered standard practice, even mandated in some prescribing information before initiating these treatments.
Are there other risk factors besides genetics?
Yes. Other factors that seem to increase risk include the dose of the antibody, and importantly, the presence of baseline cerebral microhemorrhages, or superficial siderosis, on the pre-treatment MRI scan. Patients with a higher burden of pre-existing vascular amyloid pathology seem more prone to developing ARIA when treated.
The clinical management warnings here sound absolutely vital, especially concerning potential drug interactions. What are the key concerns?
They are a major clinical focus, absolutely. Because ARIA fundamentally involves vascular fragility and hemorrhage risk, the concomitant use of anticoagulant medications like warfarin or direct oral anticoagulants like apixaban is generally strongly discouraged or even contraindicated in patients receiving these anti-amyloid antibodies. The risk of developing a severe, symptomatic intracranial hemorrhage appears significantly heightened in patients on both therapies.
What about antiplatelet drugs like aspirin?
The data there is a bit less clear, but caution is still advised, especially in patients with higher ARIA risk factors like APOE4 homozygosity or many baseline microbleeds. The risk-benefit needs careful consideration.
And there's a critical issue regarding misdiagnosis, isn't there? ARIA symptoms mimicking stroke.
Yes, this is a huge potential pitfall. A patient experiencing symptomatic ARIA, maybe sudden confusion, headache, focal neurological deficits, might present very similarly to a patient having an acute ischemic stroke. Now, the standard treatment for ischemic stroke within the appropriate time window is thrombolytic therapy, drugs like alteplase, TPA, designed to dissolve the clot. However, giving a thrombolytic agent to a patient who actually has ARA, particularly ARIA-H, could be catastrophic, potentially converting small hemorrhages into massive, fatal bleeds. There have indeed been reports of fatal, multifocal intracranial hemorrhages following thrombolytic administration in patients who were being treated with anti-amyloid immunotherapy.
So the bottom line is,
The bottom line is that if a patient on one of these therapies presents with new, sudden neurological symptoms suggestive of stroke, ARIA must be strongly considered in the differential diagnosis. Urgent brain MRI, including sequences sensitive to edema and hemorrhage, like flare and Graysway, is necessary to differentiate between ischemic stroke and ARIA before any thrombolytic therapy is even considered. The clinician has to assume it could be ARIA until proven otherwise by imaging.
wow. So ARIA really forces clinicians to slow down, image first, and verify the diagnosis before jumping to acute stroke treatment. How does this whole experience with ARIA, the specific safety signal from anti-amyloid MABs, inform the development and safety considerations for other advanced therapies, like gene therapy?
The lessons learned from ARI are having a direct and significant impact on the gene therapy field, particularly concerning the use of recombinant adeno-associated virus, RAAV vectors, which are currently the leading platform for in vivo gene delivery. What ARI reinforces is that the risk of serious adverse events with these complex biological interventions is often profoundly dose-related. In AAV gene therapy, we've seen that the high vector doses sometimes required to achieve therapeutic levels of gene expression in target tissues, like the liver or muscle, correlate directly with an increased risk of severe systemic adverse events. These include dose-dependent hepatotoxicity, liver injury, and in some cases a dangerous syndrome called thrombotic microangiopathy, TMA, which involves blood clots in small vessels and organ damage.
So similar to how higher antibody doses increase ARIA risk, higher vector doses increase AAV toxicity risk. Is the field adapting its approach based on this?
Yes, absolutely. The toxicity signals seen with high-dose AAV, informed partly by experiences like ARIA with other biologics, are prompting a significant consideration shift in the gene therapy field. We're moving away from the initial, perhaps slightly naive one-and-done high-dose paradigm towards exploring strategies involving slower and lower dosing, potentially fractionated dosing, or developing more potent vectors that can work at lower, safer doses, all aimed at reducing systemic toxicity while maintaining efficacy.
And what about managing the immune responses? ARA management involves corticosteroids. Is there a parallel in gene therapy?
There's a very strong parallel. The management of ARIA flare-ups often involves using corticosteroids to reduce the associated inflammation. Similarly, managing the immune responses to the AAV vector itself or to the newly expressed transgene product is a critical challenge in gene therapy. We now know that pre-existing or newly developed T-cell responses against the AAV capsid proteins can limit efficacy and cause toxicity, particularly liver inflammation. As a result, aggressive proactive use of immunosuppressants, often starting even before the gene therapy infusion and continuing for months afterward, has become standard practice in many AAV gene therapy trials. This typically involves corticosteroids, but sometimes also other agents like tacrolimus, a calcineurin inhibitor, or even rituximab to deplete B cells, are used to try and control these vector-related immune responses and prevent loss of transgene expression or organ damage. The need for careful immune management is a common theme.
Okay, and finally, how does the rigorous safety profile of complex originator biologics, like these anti-amyloid MABs with their ARIA risk, influence the regulatory pathway and requirements for future biosimilars of these drugs?
It significantly raises the bar and emphasizes the critical need for regulatory diligence. When a regulatory agency like the FDA or EMA is considering approving a biosimilar version of a complex biologic that is known serious safety concerns like ARIA or requires specific risk management strategies like APOE genotyping, the standard for demonstrating biosimilarity is appropriately high. The approval relies on the totality of the evidence, meaning the biosimilar manufacturer has to provide extensive analytical data showing high structural and functional similarity, pharmacokinetic and pharmacodynamic equivalence, and crucially, comparative clinical data. Given the serious, often immune-mediated toxicities seen with many complex originators, the comparative immunogenicity assessment becomes paramount for any proposed biosimilar. The manufacturer must demonstrate through clinical studies that their biosimilar product does not generate any clinically meaningful differences in the type, frequency, or severity of immune responses, like anti-drug antibodies, compared to the originator product. Ensuring comparable safety and immunogenicity is absolutely critical before a biosimilar for such a complex agent could be approved.
And tying it right back to the APOE epsilon 4 genotype and ARIA risk, this seems like the perfect, maybe even starkest example we have right now of pharmacogenomics, PGX, directly determining treatment access and management for an advanced therapy.
It absolutely is. It represents the ultimate clinical integration of PGX into routine practice for a specific drug class. Using a genetic marker like the APOE genotype to predict risk for a serious adverse event like ARIA is no longer just an academic exercise or something done retrospectively. It has become an essential prospective component of personalized decision-making for these anti-amyloid therapies. It forces a discussion between the clinician and the patient about the highly individualized risk of ARIA based on their genetics, weighed against the potential therapeutic benefits of the drug. This kind of genetic risk stratification is now an indispensable requirement for deploying these powerful, complex treatments as safely as possible. It's really the embodiment of personalized medicine in action. #tag outro.
What a journey through the world of biologics. We've really seen that the core distinctions boil down to biologics being these massive, complex molecules made in living systems, targeting extracellularly and lasting for weeks in the body.
Whereas traditional small molecules are synthetic chemistry, small enough to get inside the cell, often targeting kinases, metabolized quickly by the liver, and having much shorter half-lives.
And we learned how that fundamental difference in mechanism translates directly to their unique risks. Biologics carry these characteristic immune-mediated risks like cytokine release syndrome with RT cells, or the immune-related adverse events with checkpoint inhibitors demanding complex monitoring and often anti-cytokine or immunosuppressive management.
Exactly. And the ARIA safety signal from the new anti-amyloid therapies powerfully illustrates how personalized risk assessment, increasingly driven by genetic markers identified through pharmacogenomics like the APOE genotype, is now becoming absolutely required to navigate the benefit-risk equation and safely deploy these incredibly powerful but complex living drugs or antibody therapies.
Which really leaves us, and you the listener, with this final thought to mull over.
If the APOE epsilon 4 genotype already determines, to a large extent, who can most safely receive the current generation of anti-amyloid immunotherapy, and if we know that personalized genetic risk stratification is becoming increasingly essential for predicting and managing the potentially severe immune responses to CAR-T cells and AAV gene therapies, how fundamentally will personalized medicine driven by pharmacogenomics and other biomarkers change who receives and, perhaps more pointedly, who is excluded from receiving these incredibly powerful and expensive advanced therapeutics in the next decade? What does true equity of access look like in an era of genetically stratified risk?
This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently. where he keeps an up-to-date and active list of all disclosures.